So I will just share with you some case presentations. These have educational purposes, so you're encouraged to unmute yourself and give your opinions. It doesn't have to be specifically on the case I'm showing, but it's just to see how you treat relapsed refractory Hodgkin lymphoma. Okay, so this is a 44-year-old man who was also diagnosed with stage 3 nodular sclerosis Hodgkin lymphoma in 2018. He received ABVD for 6 cycles, and he had a first metabolic complete remission. 11 months after this complete remission, he had a new adenopathies, and with a biopsy-proven relapsed Hodgkin lymphoma, he received ICE for 2 cycles and achieved a second complete remission and autologous stem cell transplantation. And while on VV consolidation, he had a new relapse. Next slide, please. In May 2020, 3 months after last dose of VV, the patient presented again with B symptoms and adenopathies. A new PET-CT confirmed these adenopathies, and a new biopsy confirmed a relapse after autologous stem cell transplantation. He had a brother who can be a donor, and he received pembrolizumab plus GVD for 4 cycles and achieved a third complete remission and consolidation with big after identical stem cell transplantation. So next, please. So the questions about this setting is, with an early relapse after autologous stem cell transplantation and VV consolidation, I think some of them have already been answered. Would you consider only a anti-PD-1, or are we ready to use this combination? Oops. Can we go back? Thank you. Combination with chemotherapy. In this setting, with a young patient who has a donor, would you always consider allo as a best option? Or can patients with metabolic CR continue with pembro? Should allo be always considered? If we do go on to allo, how long do you wait for anti-PD-1 to wash out before allo? And if you'd like to comment on your experience on the toxicity related to GVD after using anti-PD-1, would you consider MAC conditioning for this patient? And is there a role for maintenance or radiotherapy after allo in patients who are in CR? So I think we have lots of different questions in this setting. I will encourage any of you to start giving any opinions.
We typically would use a single agent checkpoint inhibitor or pembrolizumab of nivolumab in those patients rather than in combination with chemotherapy in this setting. The response rates are pretty high, as you know. And to limit toxicity, we would use it as a first approach. Only if there is no response, or we would add chemotherapy or consider some other agents in this space.
And if patient is in CR after pembro, do you always go on to allo? Or how do you select your patients? Okay.
No, we don't. We typically, we actually have a very few patients going to allo nowadays. So our allo transplant for Hodgkin's has decreased significantly. But there's a very controversial issue with the new therapies available, including checkpoint inhibitors. But you know, we have a number of patients which achieve very good responses and can be retreated at the progression. And usually after discussion of potential toxicities related to allo, patients, a lot of our patients would prefer to wait if they are in CR. And you know, if they're progression later on, particularly after significant time, the PD-1 inhibitors typically would work again.
Great.
And in order to decide which patients go to allo, would this patient who had an early relapse, would that be a consideration to go into allo?
Not for me. I think what will be more important is how this patient is going to respond to PD-1 inhibitors. So if the checkpoint inhibitors actually cause producing good response, this would be probably more important than the early relapse post-transplant. Others may have other views.
Any other views? Or what if the patient does not achieve a CR? a very good PR, but still hypermetabolic lesions in PET scan after checkpoints.
We will probably let the patient on the nivolumab because pembro is not available here until the patient is really progressing. So, but this is as Greg said, this is always the discussion. So we discuss with the patient different possibilities, and I have to tell you that the majority are reluctant to go to the allo if they could be on the immune checkpoint. This is not a physician decision only.
How about your experience of toxicity with allo after PD-1? Any transplanters?
Yeah, we had some severe graft-versus-host disease years ago. So by the using of cyclo, we reduced dramatically the cases of, and we also analyzed in vitro the activity of that. Nivolumab is circulating for months after last administration. So I think you have to do something because not you're going to get a high T-cell response in those patients.
So how long do you think we should wait for the anti-PD-1 to wash out?
Yeah, but we found anti-PD-1 in the serum of the patients 4 months after the last administration. So we tend to, in that case, we discussed the case, but we usually in those refractory patients, we try to go to transplant with a good response, and we don't require a complete response. With an excellent partial response or complete response, we put the patients on allogeneic stem cell transplantation with cyclo, and we try to do that 1 month, 1.5 months after the last dose of nivolumab or pembro.
My understanding, Astrid, is that those cases were reported initially, and I think everybody has seen that, but that some transplant team found that with a more aggressive management, prophylaxis, conditioning regimen, early intervention with GVH more aggressively, they still are ready to handle this patient. I don't know if there are published data supporting that, but my understanding is that they are less afraid of these patients that they used to be 5 years ago. So I think waiting is a risk for these patients. So I probably will really recommend to really discuss seriously with the transplanters and the team on how to optimally manage this patient, but not take the risk of missing the opportunity if the patient is a good, probably CR or VGPR. I will not put in allo a patient with a PR. I mean, I don't know what VGPR may mean now with PET, but at least the PR patient is probably not a good candidate for allo.